right, so we'll go ahead and get started on Chapter 10 of Patient Assessment. This is part two. It should be the final part of this. So this is the part where we'll start talking a lot about interviewing, right? Interviewing patients and history taking. So I'll share a quick anecdote when we get started with this one. I had a physician tell me yesterday, or 2 days ago actually, that 80, so there's this condition called appendicitis, right? And he was telling us about the study where 80% of the appendicitis diagnosis is done off of physical exam and history taking. And that lab test and imaging test, MRI, CT, sonogram, every lab test you can imagine, is only about 20% useful in diagnosing this condition. And so what does that mean, right? We're taking a fairly common condition in kids called appendicitis, and we're saying that really, with your physical exam, that's about 80% of getting to the right diagnosis. So if we're, again, a monkey can read a CT report, right? It tells you in black and white what it says, and that's not always useful to diagnose the condition or not diagnose the condition. So, it's just kind of another point that I want to make, that he was using some exact numbers on the study, but basically he's saying 80% of diagnosis should be physical exam, and I agree with that. So a big part of this is history taking, though. So just figuring out, interviewing a patient, right? What's the difference between an interview and interrogation, right? Interview is giving someone information that they're willing to give. Interrogating someone is as interviewing someone kind of against their will and trying to get information they don't want to give up. Okay, so we interview patients. Okay, and we can do this through history taking. So history taking provides details of the patient's chief complaint and an account of the signs and symptoms. And we want to gather as much history as possible on scene from the family and the friends and the bystanders. And I've already said this. And medical information tags like a medical alert bracelet or whatever. The health app in the phone, their medication list, whatever. Discharge summaries. There's a lot of information we can gather on scene. And document all our information gathered. Okay, so every chart's going to have their medical their medical history in there, their medications they're taking, and their allergies. Every single chart, even a dialysis transfer, you're going to have to throw that in there. Okay, it's part of their medical record. Okay, now the history taking, you're going to investigate the chief complaint, and you're going to ask simple open-ended question. What's an open-ended question, right? An open-ended question is, tell me how you feel. That could be like sentences long, right? Versus saying, do you feel bad? That's a yes or no question, right? And that's a closed-ended question. We want to avoid those initially. So we start off with open-ended questions. So my go-to is, what's going on today? What caused you to activate the 911 system today, right? Like that's a genuine question of, like, it's very open. So they could answer that. Instead of just saying, did you call for chest pain? Right? That's not a good leading. It's a leading question, and then B, it's close ended. Right? What's a leading question? A leading question is where I'm leading you to answer the way I want you to answer. So me saying, "Did you call for chest pain?" Right? I'm confirming you called for chest pain. Right? Right? I'm leading you to answer that. We want to avoid those generally, especially at the beginning of your interview. So use eye contact. Remember your body position and language, and your body language speak a very large amount and how confident you are. So if you walk in and be like, "Hi, my name's Hunter. I'm an EMT, and I'm gonna ask you some questions," right? They don't care. Like, dude, you lost them. Okay, you got to walk in there and be confident. Say it with your chest, and let them know that you're here to help and you know what you're talking about. Okay, and if you don't, fake it. Okay, fake your confidence. You got to do that. You really, I'm telling you guys. I started doing this when I was 18. I looked like I was 12 back then, prior to medical school. And basically, I would have to sell to them that I am competent in this, because what they saw was a 12-year-old boy walking into their house. And I would sell them the 30-year-old EMT, right, that was very confident. And so you would have to do that. And you have to do that. Okay? Have to be confident. You have to carry yourself. You have to be professional. Make sure your uniform looks good. Okay? Do not interrupt the patient. I'm terrible about interrupting patients, but I really have to sit on my hands sometimes and let them talk. And be empathetic. What's empathy? Empathy is walking a mile in someone else's shoes. So you have to put yourself in their shoes, right? And say, oh, they called EMT, and now there's 3 firefighters, 2 ambulances, or 2 paramedics sitting in my house. That's overwhelming. So you have to be empathetic of that and be supportive of that. Okay. Now, interview, investigate the history of present illness. So you're going to use OPQRST, so the onset, provocation, palliation, the quality, radiation, severity, and time. Okay, so onset of the OPQRST, you have to know these and follow these in this order. When did the problem begin? What were you doing? So let's just use chest pain. So, oh, I was gardening and it began 1 hour ago. That's the onset. Okay. Does anything provocation does in palliation? So provoke is to like make something worse, and palliate is to relieve, right? So does anything make it? So I'll ask the patient. This is an open-ended question. Does anything make it better or worse, right? And they're going to say yes. If I get up and walk around, it's much worse. If I sit in my chair, it seems a little better. Okay, that's provocation and palliation, right? What's the quality of the pain? So I'll say, what does the pain feel like? And if they look at me like I'm crazy, I'll be like, is it a burning pain, stabbing pain, sharp pain, dull pain? What type of pain is it? And they'll say, oh, it feels like a lot of pressure on my chest. Okay. So we can use that. Okay. So sometimes I will lead the question on those. Describe your pain. Is it burning, stabbing, itching, pressure, sharp? You'll kind of push them. That's what I mean. Because if you didn't say describe your pain, a lot of times they'll be like, well, it hurts. Well, yeah, but like describe it for me, okay? So region and radiation. So radiating pain is pain that travels from one area to another, right? So, you could have chest pain that radiates into your jaw and your arm. Okay, that's radiating pain. Now, referred pain is a little different. This is pain that exists in more than one place. So I'll just draw this on this guy. Let's say he's having abdominal pain, right? Let's say he's bleeding from his spleen. Okay, spleen in this patient's left side. So he's bleeding from the spleen over here. Well, we tend to fill this up into our neck. Okay, it's called Cursine, and so it's a referred pain where the patient will be complaining of left shoulder pain, and after a baseball bat to the ribs, and you're like, oh, that shoulder pain is from bleeding on the phrenic nerve, and that runs up through the neck, so that's referred pain. Okay, you'll get the same. A better example is gallbladder, right? So if someone has gallbladder pain, a lot of times they'll fill that up in their neck, their right neck. Okay. So severity. So ask the patient on a scale of 0 to 10, not 1 to 10, 0 to 10. Um, Describe your pain for me, okay? And so I'll ask them, and so they'll go, oh, I've had this happen. Oh, it's an 11, right? And they're like texting on their phone and Snapchatting. Okay, I still document that they said it was an 11, but I ain't buying it. So you gotta use that. Pain subjective. My pain of a 4 might be your 10, or vice versa. So pain subjective, but do use your context clues in that, right? The patient that's laughing and giggling is probably not experiencing a 10 out of 10 pain. And so you can use this clinically. So what I'll do for a child is or even adult, this is what I say, this is my phrase. On a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain you could ever possibly imagine, what would you rate your pain right now? Okay. And that's a pretty direct question to answer. Okay. And for a kid, I'll say, hey, buddy, on a scale of 0 to 10, 0 being no pain at all, 10 being the worst pain you could ever possibly imagine, like pooping out a cactus, what would you rate your pain right now? Right. And I stole this from a pediatric doctor when I was working at Cook Children's, right? Pooping out a cactus is a 10. And so they'll answer the question. And timing. So when did this start? How long has this been going on? Has this ever happened before? Right. These are all timing questions. So we can have interventions, right? So you need to ask about any treatment prior to EMS arrival to avoid overdosing. So you want to make sure that they didn't take some nitroglycerin prior to you getting there. The other thing too that I'll say on treatment interventions is you want to do an OPQRST prior to any intervention, document it, and then after any intervention, document it again. What does that mean? That means if we do like a splint on a broken arm, we do our OPQRST and we document that, and then we will say the same assessment after it was splinted, and we will document that. Okay, so their pain was a 10, and it was this, and blah, 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 blah. I splinted, and now this is the OPQRST, and it's improved, gotten better, or the same, So identify the pertinent negatives. Remember, pertinent negatives are, if it's pertinent, it means it needs to be a part of your story. But if it's negative, it's a false finding. It's a negative finding. So you could say a pertinent negative is they're nauseated, but they're not vomiting. Or they have shortness of breath, but they're not coughing. That's the second part of that. The not coughing is the pertinent negative. Okay? And so these pertinent negatives become important in your documentation and in your report because they show that, well, Hunter knew that they weren't coughing and that was clinically relevant. But if I just don't put in the fact that they're not coughing and I get called up to a witness stand or in front of a medical director or an EMS director and they're like, what happened on this call? And I have a bare bones report that doesn't document any pertinent negatives, then I'm in trouble at that point. That was negligent. Okay, that wasn't good patient care. So we'll investigate the past medical history. We use sample, okay, and it actually should go in this order, and I'll explain why. Signs and symptoms, what's going on today, right? Allergies. The reason that allergies is way up high here in the algorithm is because if they go unconscious, we need to know what they're allergic to really quickly, like way up high. Because the rest of this is important, but what's going on today? Are you allergic to any medicine? That's what I really need to know from you before you go unconscious, okay? If they were to go unconscious, their medications, their pertinent past medical history, right? I don't need to know about, I don't need to know about their Botox injection last week. Maybe I do, but like what I do need to know is like, oh, I've had facial reconstruction surgery 5 times. Like, oh, that's important, or whatever. So like basically, you have to dig through like what's pertinent medical history. Okay, you don't need to know every last bit of their medical history, but what's pertinent to today generally is what we look for in emergency medicine. Last oral intake and last menstrual cycle. So the way we ask this is, when was the last time you had anything to eat or drink, including water? Right? Oh, it was 2 minutes ago. Great. Last oral intake was 2 minutes ago. The last menstrual cycle, how we ask this is, you write this down. We ask, when was the first day of your last menstrual cycle? Okay? That's what we need to document. The first day of your last menstrual cycle. Typically, it's 28 days between the start of one period and the start of the next. Right? The start of one period episode of bleeding to the start of the next episode of bleeding. And so that's what's typical, but I hate to break it to you. Women aren't time clocks. So sometimes it's 30 days, sometimes it's 40 days, sometimes it's 27 days. I mean, it varies, okay? But the ideal is 28 days, okay? And the events leading up to the injury or illness, okay? What were you doing? Again, what, were you gardening? Were you mowing the lawn? Were you up on the roof? Were you taking a shower? Were you pooping? Whatever. So alcohol and drugs, these are signs and symptoms while under the influence of alcohol and drugs, may be confused and hidden or disguised. So what does this mean? It means drug patients are difficult to assess, okay? Or intoxicated patients, drugs or alcohol, are difficult to assess accurately because it could mask their pain, it could mask their cognitive ability to answer your interview questions. So keep that in mind. So generally we can't let these patients refuse medical care as a generality. You can't, okay, because you can't fully assess them, and we can't really determine capacity to refuse. Not competency, capacity to refuse. So patients may deny abuse of alcohol or drugs. Yeah, okay, cool. So physical abuse or violence. So again, we have. I strongly disagree with your book on this one, but you have to report all per them. Report all cases of suspected physical abuse or domestic abuse to the appropriate authorities on infants and the elderly and those that are mentally disabled. Let me add that. Okay. Now with this, if you get called for priority 2 abdominal pain, right? Start transporting this 42-year-old lady, and she tells you, my husband punched me in my stomach. That's why my abdomen hurts. Okay? That's not, you legally cannot just call law enforcement and say, go arrest the husband. Right? As an adult, she has the right to endure that. And I know that's weird. It's not my favorite thing to report, but I'm just letting you know. As an adult, you have the right to make bad decisions and be abused. Okay? Now, who doesn't have the right for that to happen to them is children, elderly, and the mentally incapable. That's when it's a mandatory reporting. Okay? And I really hate going against your book on this, but your book's wrong on that. They're very wrong on that. And I've had so many questions in medical school and paramedic school on this that's why I'm going against your book and saying they're wrong. Now, sexual history. You don't get this a whole lot. I don't ask this a whole lot. I only ask if it's very pertinent in emergency medicine, right? So some patients find sharing information regarding their sexual history uncomfortable. Wow. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant. Can't stress that enough. Hunter, what if they haven't had a period? It is possible. Okay, so they can tell you 10-year-old lower abdominal pain, lower abdominal mass, right? Nausea, vomiting for the past 3 weeks. They could be pregnant. Okay, it's gross. It's not my opinion. I'm just telling you that could happen. So yes, you can get pregnant prior to your first known period. Ask about menstrual periods, sexual partners, urinary symptoms, and possibility of sexually transmitted disease. Okay, so yeah, you don't jump into this very often, but if you do, you got to do it with some tact. Maybe have a chaperone. If you have a female partner, maybe let her handle that. if it's a female patient and vice versa. But typically, I'll say this. Uh, I'll say this. Get what you got to get. Okay. If they have, you know, vaginal discharge and vaginal itching, yeah, I may need to ask these questions. But if they have shortness of breath, I don't need to ask about their sexual partners. So just extrapolate this information when it's clinically relevant and appropriate to do so. Special challenges in obtaining a patient history. So, there's a rule in negotiations, right? The first to talk loses. Let them talk. Let them tell their story. People like to be heard. Okay? Be patient. Use uh, close-ended questions. I only use those if they're like short of breath or towards the end of my interview where I'm just trying to lock down some details. Okay, a close-ended question is like generally yes or no, or it takes one word to respond to, one or two words. Use for nonverbal clues. So if the patient is like every time you ask a question, they're getting irritated and they're gritting their teeth and they're getting mad. Cool it, slow it down. Okay, you're overwhelming them. They're getting angry. So just use nonverbal cues sometimes. If you're making them uncomfortable, or if you notice they're more comfortable with your partner or the firefighter or the police officer, let them talk to them. Okay, I've had that happen. Now, if they're overly talkative, it could be due to excessive caffeine consumption, uh, cocaine, methamphetamine, Adderall, right? I saw a meme today. It was talking about that's what it was. It was a Colombian snowstorm in the nostril, and they're talking about cocaine. So I just thought that was kind of funny. But if they're real amped up, and let me tell you this too. This could also be to mania. If someone's manic or maniacal, right? It's schizophrenia, bipolar disorder, you'll see that occasionally where they become overly talkative, what they call pressured speech. Okay. So direct the patient to stick to the facts by summarizing statements frequently. Okay. So if someone has multiple symptoms, sometimes what I'll ask the patient, they'll be like, oh, okay, well, I have abdominal pain and my right leg swollen, and I get short of breath when I walk to the car, and my hair's been itchy, and my right eye just been feeling weird lately, and I have a toothache. So, and that happens sometimes when you get on scene. I'll ask the patient, okay, tell me what's the most important to you today. What's very important to you right now? And if they still have a long list, I'll say, give me your top three. Okay. So you have to kind of do that sometimes, and you'll have patients do that. They'll give you every single complaint they can think of. Okay. So spend extra time assessing these patients. Make sure that they know that they're heard and and that you care, and just know that these are still important complaints to them, right? These are still issues for them. So we don't just write them off or dismiss them, but you could kind of prioritize, help them prioritize. So history taking. So if they're anxious, expect the anxious patients to exhibit signs of physiological shock, right? So physiological shock is kind of like it's not true shock, but they could potentially pass out, or get dizzy or something like that, tachycardia. Notice it says physiological, not pathological shock. Physiological is a normal response. Pathology is part of disease. So be aware that emergency responses involving uh, anxious and hysterical patients can turn violent. And I've seen this, right? To where the anxious patient that failed the exam starts becoming violent and irritated or aggressive, right? So just be aware, this is where situational awareness, make sure you have a clear shot to the exit, request law enforcement if necessary, just protect yourself, you know? We don't want to harm them, but we also don't want to get harmed. So just protect yourself. So do not take. So if someone's anger, or the patient's anger, are hostile, sometimes you just gotta know when to hold them, know when to fold them, right? Know when to walk, know when to run. And Kenny Loggins, or no, not Kenny Loggins. Who sings that? It's called Poker. Anyways, so don't take the anger or frustration personally, and do not become angry yourself, right? So, man, I've been verbally accosted by patients before and just cussed out, and they just it happens. You got to keep in mind they could be tripping out on methamphetamine and just on a bad trip, and you're the closest thing to them. I've had patients in pain just go belligerent on me, and I'm doing everything I can for them. And just don't take it personal. Just realize this is a bad day, perhaps one of the worst days of their life, and you get the opportunity and the blessing to be there to help them. And you being a diva and giving them attitude back isn't going to fix anything. It's just going to make it worse. So sometimes you just got to roll with the punches, and just sometimes I got to know when to back off. I just got to be like, okay, well, I'm not going to ask you any more questions. We're just going to take you to the hospital, and I'll document that. Patient became very hostile and aggressive with further questioning and interviewing. So I paused the interview to try to de-escalate, right? So sometimes you just document that, and it just happens. So don't take it personal. Everyone, they're having a bad day. In fact, it may be the worst day of their life. And so just, yeah, roll with it. It's okay. Water off a duck's back. So, intoxication. So, if the information may not only be difficult to get, but it could be unreliable. So, their complaints, you may have to really fish to try to get what's going on, but even what they're giving you may not be accurate. That happens in intoxication. So, never assume the patient's condition is a result of alcohol consumption. Remember, hypoglycemia, stroke, postictal states can, meaning after a seizure, can imitate alcohol intoxication. Really, DKA, really metabolic derangements can look like alcohol intoxication. So if someone's crying, trust me, I'm the guy that would love to pet him with a broom and tell him it's going to be okay. But I really don't do that. I'm just being funny. A hand on the shoulder, letting them know, hey, it's okay. We're here to help you. We're going to take good care of you. How can I help you? Is there something you'd like to talk about? Lowering your voice and being very nice and gentle and calm. Right? Remember, chaos is contagious. So just releasing the chaos from the scene. Maybe if you can cut some people loose, let some firefighters go, your first responder agency, just let them go, get some people out of the room, just try to de-escalate the situation. Sometimes I'll do stuff like that. Okay. So treat them with respect and dignity. Okay. You'll see grown men cry and it's okay. No judgment. It happens. It's a normal response. Okay. To grief. So depression symptoms include sadness, a feeling of hopelessness, restlessness, and irritability, which is really weird, right? To where you think, what? Like, how is restlessness and irritability relate to like sadness and feeling of hopelessness, right? It happens. So depression has this really wide spectrum. So it can be difficult to diagnose, actually, to accurately diagnose. And so just know that there's a wide spectrum of depression. Okay. Patients won't eat with depression. They'll have eating disturbances, or they'll eat too much. They'll sleep or not sleep too much, or they'll sleep too much. So there's just like there's one side of depression and the other end on the spectrum, and that's what makes it kind of weird. Like what in the same disorder, you'll have people that sleep too much, but then you'll have the people that don't sleep with terminal insomnia, right? So it's just this really weird, difficult to diagnose thing. Very, very, very common. And you're not expected to diagnose this depression in the pre-hospital field, by the way, ever. It's very difficult. So confusing behavior or history. So be aware of medical causes that can cause a patient to report a confusing history, right? So at some point, you might just have to look at the family and be like, okay, I need to know what's actually going on because the patient's confused. They're altered, right? They have an altered level of consciousness or awareness, okay? And patients with limited cognitive ability. So, you know, you need to be careful with these patients and still treat them as adults, right? So even if they're intellectually disabled or have a limited cognitive ability, Down syndrome, autism, mental retardation, something like that, you still need to try to question them and see where it goes. You might see that the patients really want to engage in the interview process and answer the questions for themselves. And you can engage in that for a while and try to get some information, but you might have you or your partner fact checked or dig a little further with the patient's caregiver or parents or spouse or something like that. So just be aware, you can use both. Just be respectful, I guess. Don't be a jerk. Language barriers. So I'm in South Texas right now, and a lot of the patients speak Spanish, so I'm learning a lot of Spanish really quickly, and this is really difficult. So we have translator lines. The use of an interpreter, if that's listed, is always going to be the most correct answer. But you could use translator lines, mobile apps like Google Translate or something like that. Hand gestures, writing stuff down. But I just fumble through my Spanish and hope for the best most days. Although that's not the right thing to do, but that's what I have to do. Hearing impairments. So ask the patients clearly and slowly your questions. Don't obstruct your mouth, right? They read your lips. And people think that getting loud with a high-pitched voice makes it better. It doesn't. A lower-pitched voice and speaking very clearly and slowly is going to be your best bet for the hearing impaired with your mouth uncovered. Visual impairments. So you want to identify yourself verbally and stay in contact with the patient. Maybe let them know some things like, hey, I'm going to pull you out of the ambulance. It may feel like you're falling. You're not. I got you. Don't reach out and grab anything, right? Because those are things that are very foreign feelings to be lifted out of an ambulance on a stretcher or loaded into an ambulance on a stretcher. So make sure you're explaining all parts of the procedure. Okay, I'm going to put this blood pressure cuff on your right arm. Is that okay? Okay, it's going to give you a squeeze for the next 10 seconds or so, right? And explaining everything you're doing to the patient. Because, I mean, really imagine you're not feeling well, right? Like you have chest pain or something like that, or abdominal pain, and you're blind. and you have a bunch of random people start jolting you around and doing procedures to you. It's very scary. So keep that in mind with the visually impaired. Obtain vital signs, and I hate that I'm reading off the slides to you guys, but I kind of have to. Obtain vital signs and perform a systematic physical exam of the patient. So assess and document their level of consciousness, their respirations, pulse, blood pressure, skin condition, blood glucose, and pulse oximetry. Okay, cool. So in our secondary assessment, this is where we're going to start digging into like, are really digging into like vital signs and the physical exam, okay? And so we're going to assess vital signs using pulse oximetry, which remember that measures a percentage of saturation of hemoglobin in the capillary beds. We typically do this in the fingers, okay? And it uses light passing through the finger and through a sensor on the other side, okay? It's a useful assessment tool to determine the effectiveness of oxygen therapy, bronchodilator therapy like albuterol, and artificial ventilation. So pulse oximetry is the real deal. It's a great tool, okay? Um, so pulse oximetry, right? Do not confuse pulse oximetry with hypoperfusion or known anemia. So if someone has known anemia, their pulse oximetry might read low. Okay, carbon monoxide will cause it to read really, really high. So it's because the hemoglobin is in fact saturated, but you don't really know if it's saturated with oxygen or carbon monoxide in this case. Carbon monoxide is the byproduct of combustion. So if something burns, like exhaust or a house fire or something like that, you'll breathe in carbon monoxide and it binds to hemoglobin at around 240 times greater affinity than oxygen. So what that means is the hemoglobin gets really, really bound to carbon monoxide. So remember, pulse oximetry is just bounding or measuring how much of the hemoglobin is bound to something, not necessarily to oxygen. Typically, we use it for oxygen, but it could also be carbon monoxide. So remember, you're just measuring the bound hemoglobin percentage saturation. Usually it's oxygen, but it could be other things. So that's why we have to be clinicians and not technicians, and we have to think through these issues and think, oh, wow, it's the first day of a cold winter and they just lit the heater. Yeah, it's carbon monoxide. Okay. Cold extremities as well. This will jack up pulse oximetry. The other thing that'll mess it up is too much light. So it uses light. So a lot of times I'll take the patient's hand and I'll put it up underneath a blanket to eliminate all light other than the pulse oximetry. And I find that to be very effective. Okay. So non-invasive blood pressure monitoring, NIBP, all right, very, very, very useful tool. Our monitor will do this. I do think you should be taking manual blood pressures while you're in EMT school and really when you get out. But basically what this does is it uses pressure. So instead of using sound like what we'd use with the stethoscope, it uses like a pressure to determine what the blood pressure is, and it's usually pretty accurate, okay? And that's what they're showing you right here. Okay. Now, end-tidal carbon dioxide monitoring, or end-tidal CO2. Basically, what this does is this measures this. You put a nasal prong in someone, and as they breathe out, right, carbon dioxide comes out when we breathe out. It goes to the monitor and it'll sample it and create a waveform. That's what they're showing you down there, and it gives you some values. It tells you how much carbon dioxide they're breathing out in that particular breath and what type of pattern it is when it's exhaled. And we'll use this clinically a lot, and it's one of my favorite tools. It's probably my single favorite tool on the ambulance. Love it. And it's very useful for measurement of perfusion, okay? So that's that. It's more of a EMT, advanced EMT paramedic level tool, but EMTs in Texas can use this, and it's very, very cool. So what we do is we'll put this on the end of an endotracheal tube, and it'll tell us if we're in the esophagus or if we're in the trachea. We need to be in the trachea. And it also tells us a lot about perfusion. So we use this in cardiac arrest. I'm not going to jump into what that is today, but it's very useful. We'll show you that in the lab. We'll do some exercises on some of the students. We'll put it in your nose and have you breathe really fast and breathe really slow and hold your breath, and you'll see it on the monitor. It's really cool. So blood glucometry. So this is glucometry is measuring the amount of glucose in the blood. Okay, what's the normal level? It depends on the book you read, but somewhere between 70 and 120 milligrams per deciliter is the normal. Okay, some will say 60 to 120, some will say 80 to 120, some will say 80 to 110. I don't care, but somewhere in there is normal. And so as we sit here today, unless you have diabetes, your blood glucose is probably somewhere in this range. And so what we do is we poke someone's finger with a lancet and we extrapolate some capillary blood, like a drop of blood, and we dip a test strip on there with the glucometer. And within about 3 seconds, it'll tell us how much blood or glucose is within that blood sample. And so we use this for diabetics and altered mental status, and it's really, really helpful. Okay. So most altered mental status patients, really most patients get this, especially if I start an IV. I already have their blood within the IV needle. So I'll just use the blood from the IV needle to get a blood glucose. It's helpful. Very cheap test too, pennies to run that test. So your full body exam. So you're going to do a full body exam in your secondary assessment, okay? And you're going to try to identify your injuries or unidentified causes, okay? So they might say, oh, I have abdominal pain. And you open it up and it's like, oh, dude, you have like this huge abdominal mass or something like that. I don't know, a hernia or something like that. So, you might use that, or you might use, so this is where we do a full exam, okay? Any patient who has a significant MOI, is unresponsive, or is in critical condition should receive a full body exam, okay? Yes. Say that again. Any patient who has significant mechanism of injury, is unresponsive, or is in critical condition should receive a full body exam. Why is that? Because we don't want to roll into the ER with someone saying they're short of breath and can't breathe, and we didn't do the full body exam to notice that their right leg is hot and swollen because they have a DVT that has now caused a pulmonary embolism. Okay, we're going to talk about that in the respiratory chapter, but I'm just pointing it out. Like, this is why we do full body exams. Okay, your focused assessment. So basically, we don't necessarily need to do a full genitalia exam on someone with chest pain, right? But we do need to do a full chest exam and cardiac exam on someone with chest pain. So in our focused assessment, we tend to focus in on what it is that we're looking for, okay? So generally performed on patients who have sustained a non-significant MOIs and on responsive medical patients with a specific complaint. Chest pain, abdominal pain. So I might do a really focused abdominal exam, okay? Based on the chief complaint, of course. So that's going to drive me into where I need to go look and do my focused exam on, and focus the attention on the immediate problem. So the respiratory system, you're going to look for airway obstruction, trauma to the chest, neck, okay? Expose the patient's chest to inspect for overall symmetry and work of breathing, retractions, subcostal, intercostal retractions, okay? Abdominal breathing, right? Listen carefully to breath sounds, noting the abnormalities. Again, I talked about this in the respiratory chapter, but, we listen right to left, okay? You can listen in the axillaries too. That's one of my favorite places. And we listen right to left, left to right. Okay, we don't listen on the right side the whole long and then listen to the left side the whole long, right? You compare one side to the other all the way down. And so we're going to look for abnormalities in our auscultation, in our exam, and you're going to measure the respiratory rate, okay? And chest rise and fall and effort. I will say when we measure respiratory rate, you don't say, hello, patient, I'm going to measure your respiratory rate. It's going to bias the respiratory rate, right? So you just do it quietly, okay? You just stare at their chest a little bit and count it, okay, without them knowing. Sometimes, too, I'll just put my hand on, like, their shoulder or, like, their chest or something, especially a kid, and I'll just count it that way with my hand moving. That's what I do, okay? The normal rate is 12 to 20 in adults. Could it be 10? Sure. Could it be 22? Sure. Okay, but normally it's somewhere between 12 and 22, okay? Now, check respirations in a responsive alert patient without making the patient aware. I just told you that, okay? Now, the rhythm becomes important because in certain pathologies, they'll have a rhythm like Cheyne-Stokes respirations or Kussmaul or Biot's or apneustic, right? There's these different respiratory patterns that we'll talk about later on, but normally it should be pretty consistent rhythm, okay? If it's irregular, it's pathology, and you need to look into why. In fact, I'll say if someone has a regular respiratory rhythm, it's bad pathology. That's usually pretty bad. And that's an emergency. The quality of breathing, right? So how hard are they breathing, okay? Do we have decreased or absent breath sounds on one side of the chest? Is there decreased movement on one side of the chest, right? Do they have stridor? What stridor? That's usually upper airway obstruction that sounds like a high-pitched sound on inspiration. It's usually related to a foreign body airway obstruction or swelling of the trachea or larynx, known in a virus called croup, okay? It happens in children. So are they bubbling or gurgling, right? The patient might have fluid in the passages in the upper airways, okay? So, you'll see this in RSV. You can also see this in pulmonary edema, right? Where they're just gurgling up pink frothy sputum, that's an emergency. So just be aware, okay? So you want to listen to the lung sounds here, right? Right below the clavicle, about an inch below the clavicle. This is one of the best places to listen to because there's not a whole lot, especially if the patient's sitting up, a whole lot of pathology that happens up here. in the emergency setting, and then we'll listen here, here, at the bases, right? What are the bases? It's right pretty much where the nipple line is almost about where the bases are. And then you'll listen to the back. I want to point out that here is the patient's scapula. So don't listen on the scapula. You're not going to hear very well. So you want to listen around the scapula. So you might listen here, 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 right? So generally avoid the scapula. You're not going to hear very well. Okay. So normal breath sounds, right? So you should hear air going in and out pretty equally throughout the lung fields. Now, we could have the tracheal sounds or the bronchial sounds or bronchovesicular sounds or vesicular sounds. What are these? It's not important. But basically, when these happen, these are areas of consolidation. So basically, someone could have pneumonia or fluid in those areas. This is, I'll just tell you how this happens. So sound travels really well through water in this case, or like a solid, okay, like pus or something, okay? So it tends to be a little bit louder when there's fluid or pus or something like that there. And then especially there's a thing called agophony or agophony where you'll like you can ask the patient, say, sauce, right? Random word, right? And you'll hear it louder in areas of consolidation. So if someone has like a right lower lobe pneumonia, and you're like, if you ask them to speak and they have right lower lobe pneumonia, it'll be louder in the lobe that has the pus in it. That's agophony, okay? Or a bronchovesicular sound. Wheezing, again, this is an expiratory issue, usually almost always from obstructive pathology, asthma, COPD, emphysema, bronchitis, bronchostasis, those things. We're going to talk about the respiratory chapter. But it's a high-pitched expiratory noise, okay? And I'm going to link below in this video a video with what those sound like. Crackles, formerly known as rails. This sounds like you take a sonic cup and you just blow through the straw and you're breathing underwater, okay? Because that means there's fluid in the lungs. Rhonchi, this is like breathing in a hot fudge shake, right? That's liquidy. It's very thick, pop, 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 plop, plop, right? So it's like breathing through mucus or snot, because that's what you're doing when you have pneumonia. You're breathing through mucus or snot. So it has a very distinct sound. Stridor, again, this is upper airway, okay? And then pleural friction rub. This is when basically we have this lubricant in our lung fields, and so basically it'll rub, okay? And it creates, like when you listen to the lung sounds, a rubbing sound, and it has very sharp pain in the area that it's rubbing. The patient will complain of severe pain. So the depth of their breathing, so each breath in and out is something that we call tidal volume, T-I-D-A-L, like a tidal wave, that is moved in and out of the breath with one single breath, okay? So this is the normal amount of air that's coming in and out. I'll have mostly in adults around 500 milliliters, give or take, okay? And so this is tidal volume. So if someone's breathing really fast, right, they're going to have a low tidal volume but a high minute rate because they're breathing really fast, or minute ventilation. But if someone is breathing really deep, right, like Kussmaul respirations, what we see in diabetic ketoacidosis, right, metabolic acidosis, you'll see an increased tidal volume in that. So instead of being 500, it might be 700 or 800, okay? And that's an increased tidal volume. So tidal volume, again, is the normal amount of air that's breathed out in a normal respiratory cycle. Or really any respiratory cycle, but normally it's 500. So the cardiovascular system, you're going to check for abnormalities in the thoracic region. You don't typically see abnormalities on visual inspection. You might see like some parasternal heave or something like that, but that would be rare. But you're going to check and compare the distal pulses. So you might feel the radial pulses on each side. Is one side stronger than the other? You'll feel the distal pulses is the radial pulse real thready and the distal pulse is really strong, or vice versa, right? So sometimes you'll want to compare that. That can be certain pathologies called corrucation of the aorta or a abdominal aortic aneurysm. We'll talk about those in the cardiovascular chapters, but sometimes we use that clinically to diagnose people. Blood pressure, different blood pressures in the right versus left arm could mean a certain pathology, again, abdominal or an aortic aneurysm, okay? So the normal pulse rate is between 60 and 100, and anything greater than 100, tachycardia. 102, tachycardia. Anything less than 60, bradycardia. Not my opinion. These are rules. These are not opinions. So you got to follow these rules. So I can tell you someone's heart rate's 102. What is that, Hunter? It's tachycardia. Okay? It's 50. It's 59. What is that? It's bradycardia. we talk about this, but if the pulse is, strong, bounding, weak, or thready, that's one thing. And if it's regular or irregular, so we have conditions where we have irregular beats in our heart, like atrial fibrillation or premature ventricular or premature atrial contractions. So sometimes we get these irregular heartbeats, and that can become clinically relevant, right? You get a patient that's called for chest pain, and you reach down, and their heart or their radial pulse is very irregular. So it's like boom, 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 right? Like that's a regular instead of boom, boom, boom. That's clinically relevant. It needs to be documented, and you need to put that into your assessment. That may be why they're having chest pain, because they're having an irregular heartbeat. Excuse me. So the blood pressure, a decrease in blood pressure could mean a lot of things. Okay, it's a late finding. Let me tell you that. A drop in blood pressure is one of the last things you'll see in shock. Okay, and the loss of blood or fluid could lead to this. Loss of vascular tone. So this would be, recapitulate. This is hypovolemic shock when we lose blood or fluid. This is distributive shock, right? Or neurogenic shock. So this could happen in sepsis, anaphylaxis, or spinal trauma. Cardiac pumping problem, that's cardiogenic shock. Okay. Overdose of a beta blocker or an antihypertensive medication, that's toxicology, right? So beta blockers, these are drugs that end in LOL, like metoprolol, labetalol, propranolol, carvedilol. These are drugs that end in LOL, and basically they block the beta system, and the heart uses beta, and so do the vessels. And so basically, if you block beta, you kind of block the heart, so you end up with, poor blood pressure. In fact, we use these medications to treat blood pressure, like metoprolol and propranolol and labetalol. Some of them. So, the systolic increase, or the systolic blood pressure is the top number, right? And so, if that number increases, that increased pressure causes the ventricles to work harder to pump out against. Okay, so a high systolic pressure means the heart has to pump really hard to eject its contents of the left ventricle. Okay, but an increased diastolic pressure, the bottom number, means that there's a lot of pressure when the heart is at rest. So, I would ask you, which one of these is worse? Well, they're both really bad, but I would rather have, I would say that having a high diastolic pressure is definitely more damaging. You have a pump that never relaxes. And so that becomes a problem. You have constant pressure on these water hoses and pumps, and so that can lead to rupture and, hyaline artery disease and all these arterial sclerosis and all these issues that can come up. Okay, fatty streaks. So we measure this in something weird called millimeters of mercury, mmHg. Hg is what mercury looks like on the periodic table of elements, so that's where we get that. Okay. It's reported as a fraction in the form of a systolic pressure over the diastolic. So 120 systolic over 80 diastolic. Okay. So most EMS systems, and we'll show you this in the lab, carry like 3 or 4 different blood pressure cuffs, like a neonate, child, adult, fat guy, or obese. So that's typically how we do that. So the normal blood pressure is 120 over 80. Okay. So hypotension is going to be somewhere pretty well south of this, maybe like 110 over 70 or 110 over 60. You get a little bit more hypotensive. And then, really anything 140 up, 140 over 90, that's more in the hypertensive range. There's not a set parameter that I want you to memorize for these. Just know that hypotension means low blood pressure and hypertension means high blood pressure. And you have to use all of this clinically to determine, is this like a medical emergency or not? There are people walking around in Walmart as we speak with blood pressures of 200 over 100. It does happen. Okay. And they're fine. Or they think they're fine. But, just realize it depends. Okay. And then, and conversely, if my blood pressure were to suddenly rise to 200 over 100, I'm not going to be fine. So this is very specific to the patient and the clinical scenario. Okay. Now, the neurological system, we use this in physical exam, of course, to evaluate the level of consciousness and how oriented they are, and if their ability to think and process and determine capacity. Okay, like I said, we could use APU, and we inspect the head for trauma. This is getting annoying. And assess for any gross neurological deficits. What's a gross neurological deficit? This could be someone who can't blink, or someone who can't speak, or someone who has garbled speech, or they speak like this, do 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 do, like Broca's aphasia or Wernicke's aphasia. So these are all things that we look for clinically for gross neurological deficit. I mean, neuro exams are very, very difficult and very in depth, and we'll talk about some of the more basic common ones, but like pupil exams, for example. So, like I have a pen light. I recommend you don't use your iPhone and shine it in someone's pupil. It's too bright. This pen light. Oh wow, did it just quit on me? No. This pen light, Laura gave it to me. Shout out Laura. And I use this. I carry it in my white coat, and they're on every ambulance, and it has the pupil sizes right here. And so basically, the pupils should normally be round and reactive to light. And what we do is we call that pearl, right? Pupils are equally round and reactive to light, pearl, okay? And so that's what's normal, okay? And so normally the pupils are on 3 or 4 millimeters, maybe 2 to 4 millimeters is the normal. And, or 3 to 4 millimeters probably. And so that's the normal. They could be a lot less or a lot more. It depends on the environment, how much light is in the room, okay? But with less light, the pupils will dilate, so they get bigger, okay? And so if you go outside, right, and it's nighttime, your pupils get really big because they're opening up, trying to bring in as much light as possible to aid in your vision. As opposed to if you go outside and it's sunny, they're going to get smaller. And the same thing could be said if I shine this light in my eye, right? My pupils are going to get smaller because there's a bright light in my eye. Well, what's happens is we have something called consensual response. So when I shine this in my right eye, my right eye gets small, but so does my left pupil. That's what's supposed to happen. Because again, they're supposed to be equally round and reactive to light, equally. Okay? And that's called consensual response. And so bilateral dilated pupils, I mean, this is weird that they're saying this, that do not react to light is typically a sign of death. Well, yeah. So is the patient that, I mean, like, yeah, it's weird. It's like cool story, but like, it's weird they point that out. But yeah, just know that, what they call that fixed and dilated pupils, right? They're fixed and they're dilated. They're non-reactive. Okay. So yeah, that does happen. Now, these pupils up here are small, right? The pupil's the black thing, by the way. The colored part's your iris. But the black thing is what we're talking about when I talk about pupils. This thing. That little black thing. And they're small, okay? That's like 2 millimeters or smaller. And so I'll tell you a condition that this happens to, which is really high yield, is narcotic overdose. So when someone's not breathing and they have a needle sticking in their arm, I'll shine my pen light in their eye, and I'll see their pupils are what we call pinpoint, and it's a narcotic overdose. We give them a medicine called Narcan, start breathing for them with a BVM. Okay. Now, these pupils look a little bit more dilated. Okay. They're fairly large. And these are unequal. So notice how this pupil's, 2 to 3 millimeters, and this one's probably 4 to 5 millimeters. Okay. This is abnormal. Now, when does this happen? This will happen in neurotrauma, like brain trauma. This can happen. That's probably the most important one you need to know. Neurological insult, you can have unequal pupils. And it's almost always to neurological insult, basically where the third cranial nerve will get hooked on this notch in the brain when it gets pushed on. And so basically when parts of the brain or the nerves, especially the facial nerve or the cranial nerves get pushed on, they don't work well. And so, you might assume that this patient's, this is probably this patient's right. But yeah, this patient's right. It maybe they have a right-sided brain bleed. Okay, I don't know. So just know. Now, what's accommodation? Okay, accommodation is when they will bring. I don't like that they're using it in this way, but I know what they're trying to say. You can't really test accommodation in the pre-hospital environment. Accommodation is really when your eyes are focused, okay? And you can like go from nearsighted to farsightedness, okay? And focus your eyes. That's accommodation. But they're also saying that accommodation could be like, which this is really convergence, when your eyes will converge inward, okay? And they're saying accommodation too is like an acceptance of light, okay? So it's accommodating to the light environment. But it's really not the use of the word of accommodation. Accommodation is when your eyes can accommodate to far distance or from nearsightedness to farsightedness. Okay, you could test this, right? If you stare at a wall and kind of like twist your eyes up a little bit mentally, you might be able to make it really clear and really blurry looking far away. You could do that same thing nearsighted, right? And that's accommodation. You're changing the shape of the lens of with behind your eye. That's actual accommodation. Now, anatomic. I'm gonna go through these because I think this is best done in the class. And so basically, what we'll do is we will palpate, and we're filling the scalp and the skull, and we're feeling for pain, deformity, crepitus. What's crepitus? That's the feeling of two broken bones rubbing together. Has a very distinct sound and feel, as you can imagine. And bleeding. And we're gonna check the face for rash and petechiae. Petechiae is blanching of the skin. Okay, so it almost looks like a little rash, like little bleeding up underneath the skin. Okay. We're going to assess the eyes. So we're going to look for bruising or discoloration around the eyes, behind the ears, which is the mastoid, right? We're going to be looking in the ears and the nose for fluid or blood or dried blood or leaking of cerebral spinal fluid, okay? We're going to look for odors that suggest the need to check for blood glucose levels, right? If someone has really high blood glucose, it smells like acetone, and that's diabetic ketoacidosis. And so sometimes you can smell that. It has a fruity smell to it. And then you're going to check the neck for swelling or bleeding, okay? So again, we're palpating. Does it feel normal? Is there like little Rice Krispie treats up underneath their neck called subcutaneous emphysema, right? And there's not, so we're just feeling, okay? We're going to palpate for signs of trauma. We're going to feel the C-spine. Is there any step-off or deformities? Is there pain when I touch the vertebrae? Is there pain next to the vertebrae, right? That's spinal versus paraspinal pain, okay? The chest. We're going to inspect, visualize, and palpate over the area of the chest, okay? If it's a female, I recommend you use the back, like a male assessing a female. I recommend you use the back of your hand and say, I'm going to use the back of my hand to push on your chest. Is that okay? Right? And I'll use the back of your hand. Why the back of your hand? Because you can still feel, but it's not as sexually provocative for the patient because your feeling is a lot less. And it's not like you're gripping and grabbing. Okay. So I'm telling you, when you assess the chest, you should really use the back of your hand. Intercostal retractions, and also let me tell you this: the back of your hand is more sensitive to temperature changes than the front of your hand. So you might see like someone feel for fever with the back of their hand. It's because your back of your hand is more sensitive to temperature. Anyways, intercostal retractions. Remember, that's the between our ribs or up near our clavicles or down near our diaphragm, up underneath our rib cage. If that's like sucking in with each breath, that's accessory muscle usage. That means there's an increased work of breathing. That's a problem. Okay, paradoxical motion with fractured ribs. This is when you have like a flail segment where you break two or more ribs in two or more places. And so you could have, when the patient breathes in and out, like a paradoxical means like like a backwards kind of movement of the chest, or a paradox means opposite. It's where it's kind of moving in the opposite direction it's supposed to move, okay? And we auscultate. Auscultate is the fancy word for listen to breath sounds, okay? So the abdomen. We're going to feel on the abdomen. So first, we're going to visually inspect. We're going to look for trauma or distension. Do they have this big old beer belly, rock hard, red hot, bleeding into their abdomen? Do they have peritonitis where I feel on their belly and anywhere I touch it hurts, right? So we gotta inspect, and then we'll palpate. So let's use an example. If someone has right lower quadrant abdominal pain, we don't start in the right lower quadrant. We start on the left upper, left lower, right upper, and the area that they're complaining of pain is the last area that you palpate. Because if you palpate a sore abdomen, a phenomenon known as guarding will take place, and they will flex their abs to where you can't hurt them. And then you just ruin the whole exam. So, because you're just going to feel abs. Yes, fat people have abs. Obese people have abs. So they will also contract their abs, okay? And so, we're going to look for bruising in the flank. So bruising of the flank might suggest a kidney injury or a pancreas injury. And bleeding around the umbilicus could suggest a pancreas injury as well, or a spleen injury. So there's different areas that we're going to look, and we're going to get into all, like, what do all these findings mean, of course, when we get into the chapters. But these are like, again, you're looking for abnormalities, and we're still looking for pertinent negatives, right? They did not have abdominal pain in any of the quadrants or guarding until I got to the right lower quadrant. They started guarding and they had severe abdominal pain. One thing I'll point out is when you assess the abdomen, I want you to support one side of the so support the other side of the abdomen with your hand. To try to because if you just push down on someone's belly, it just displaces, tissue. But if I support, like I'm holding the abdomen in and I'm feeling with my hands, right? My professor used to describe it as cat paws, right? To where I'm kind of going like this, like I'm starting with my palm and I'm really kind of feeling around, and I'm thinking, well, they have left lower quadrant abdominal pain. What's underneath that? If it's a woman, it's an ovary. If it's a male, it's not an ovary, but it's definitely their descending or sigmoid colon. So I'm thinking diverticulosis, diverticulitis, constipation, those things. So I'm thinking, what's underneath this that I'm feeling to try to guide me in my exam? Okay. Um, and then moving forward, asymmetry may suggest a swollen organ. So we could have hepatomegaly, which is a fancy word for a big liver, or splenomegaly, or hepatosplenomegaly, where they're both big, or constipation, ascites, right? There's all these different things that we could look for. We're going to look for distension that could be caused by fluid in the abdomen, in the peritoneal space. That's called ascites. It's a weird word. We see this with liver disease commonly. It's spelled like this, ascites, okay? So there could also be blood in the peritoneum. So blood on the peritoneum is very irritating. So uh, the patient will complain of pain as soon as you start pushing on their belly, okay? Obstruction or infection, and you're going to assess for the presence of rebound tenderness. Oh, what's rebound tenderness? So if I push into someone's belly, right, with my fingers, and I let go rapidly, and that is what elicits pain. That's a sign of peritonitis, really good sign of appendicitis. But the peritoneum, the sac that holds the front part of the guts, is inflamed and irritated. This is usually caused by blood. And so when you push down and you let go, and that's what hurts, the whole letting go part pretty briskly, that's rebound tenderness. That probably means appendicitis usually. Or not peritonitis, which is associated with appendicitis. The pelvis, you want to take the pelvis and you want to assess it for stability, symmetry, pain, tenderness. Is it deformed? Is it a chunk of the ileus broken off? So that's what you're kind of looking for when you assess the pelvis. Inspection of the pelvis area is not done in patients with medical emergencies, of course, but you do this in falls and trauma patients and car wrecks and stuff like that. And female patients determine whether bleeding is coming from the vaginal opening, the urethra, or the external genitalia, or the rectum. So if you look down and there's a huge blood stain on their pants and underwear, yeah, this would be one of the times where it'd be medically appropriate to go ahead and remove that clothing and visually inspect. Okay, so you might need to look like, oh wow, okay, the blood's coming out of the vagina, or it's coming out of the rectum, or it's coming out of the urethra, or it's coming from a stab wound to the thigh. Where's the blood coming from? Okay, so in male patients, you need to determine where the bleeding's coming from. Again, it can come from the urethra, the penis, right, or it can come from the rectum, or both. So the extremities. So we use DCAP BTLS. Still don't know what that means. Embarrassing. Deformities, contusions, abrasion, punctures, burns, trauma, lacerations, scars. I don't know. I can't believe I don't know what that is. I'm going to look it up in this video ends. I feel like a fool. So check for pulses, motors, function, and sensory function. And you're going to palpate each extremity individually. Again, we'll show you what this looks like in the lab, but you're like feeling for crepitus, deformity, pains, tenderness, swelling. I'm feeling, is it the same temperature all the way down the arm, right? How does the skin look? Do they feel me all the way down their arm, right? Do they only feel me on the extensor surface, not on the flexor surface or whatever, right? Like these are all things that we want to look at, okay? The posterior back, we do this a lot when backboarding. Notice someone is supporting the head, right? And someone supporting the legs and the pelvis. And this guy is assessing the back, right? He's feeling down the spinal cord and the vertebra and feeling for step off, deformity, pain, DCAP BTLS, really, OP like that's what he's feeling for going down, okay? So you start up here in the neck and you work your way down, and then you might roll them back onto a backboard, okay? So you want to keep the spine in line at all times, of course. Okay, that's what the guy up here at the head's trying to do. He's trying to support the head, so it's not just like sitting like this while you roll him. So additional physical exams, if time permits, which sometimes you will have time, you can perform, again, another focused assessment of each body system. or you could reassess if needed. And then what additional problems can be identified through the exam, right? So you need to ask yourself, what else can I find? How else can I confirm that this is appendicitis, that this is cholecystitis, that this is diverticulosis, right? And so we can do additional exams on top of exams when time and the patient and the situation permits to try to really nail in our diagnosis, okay? Now, one thing that you need to ask yourself is, and this is especially true when we start like doing chest exams or genitalia exam, is how is this going to really change my treatment choice? If my treatment's still going to be rapid transport to the hospital and stop the bleeding, and I'm already doing that, I don't really need to go too much deeper into a genitalia exam, okay? So do ask yourself that. And there's going to be scenarios where you do need to do a genitalia exam and a full chest exam, and chest exams are common. But you need to be able to sit there and explain to your boss or your medical director, well, I did the genitalia exam because I saw blood around where I thought the penis would be, right? Around the groin. Okay. And so then it's like, oh, okay, well, yeah, very well, good. So you just need to be able to justify your exams and your treatments. Okay. Again, there's a fine line between doing a detailed exam and battery and assault. And again, the patient can refuse the exam or any part of your exam or anyone doing the exam at any time. Okay. So that is the patient's autonomy and right. Okay. To refuse treatment and transport and assessment. It's their right. So reassessment, this is the last 5 slides. Hang with me, I'm tired too. So it's performed at regular intervals, and typically we reassess every 5 minutes on critical patients and every 15 minutes on non-critical patients. And so basically, we're going to identify and treat changes in the patient's condition. So as I start giving them, nitroglycerin or albuterol, whatever I'm doing, the things might change, or they might start complaining of new things or not complaining of previous things. And so my treatment can change and my assessments will change. And so this is a very common phenomenon in our reassessment, that we get re-guided and that we have to change what we're doing into a different treatment. Okay. And so the interesting thing about reassessment is it kind of takes a little bit of everything we've already talked about. It takes a little bit of the primary survey and your vital signs and your breath sounds and your secondary assessment and your focus exam, and you just kind of take what you need to do to reassess the patient. And don't get caught with your pants down in the back of an ambulance, not, because you didn't reassess the patient. Don't get lazy banging away on your computer and charting, and you totally miss that. The patient who had a soft abdomen from the car wreck now has a rock hard, rigid, hot abdomen, and they're bleeding into their abdomen, and you didn't catch it because you didn't reassess because you were busy charting. So just be real careful with that and be thorough with your reassessments, because you can get in big trouble by not reassessing and totally miss things. That's happened. You roll into the ER and they're like, dude, what the hell? You didn't tell us about this. And I'm like, dude, what the hell? 15 minutes ago, it wasn't that way. That's 15 minutes ago. You know what I'm saying? So you do need to reassess. So you want to look at vital sign trends. Is their blood pressure or pulse or pulse oximetry or glucose going up, down, staying the same? And you use those to look for trends. Are they getting better, worse, or about the same? And you're going to reassess the mental status. Is it getting better with your interventions? Are they getting worse? Of course, we're looking for trends. Okay. Reassess the chief complaint. So we'll be asking them, is your pain getting better or worse? Is your nausea better or worse? Is your itchiness better or worse? Is your rash better or worse, right? We're looking for these things. And in fact, a lot of times I'll say, is your nausea the same, better, or worse? I don't want to force them into, it is better or it is worse when it's really the same. So how you like to use the word, is your rash or your nausea or whatever, is it the same, better, or worse? That's how I think you should ask it too. Because if you say better or worse, then you're really forcing them into one or the other. And it may just be the same. And it usually is the same. So, reevaluate. I'm saying the same thing over and over again. Okay. So this is important right here. It's very important. Reassess the patient. If it's an unstable patient, it's every 5 minutes. If it's a stable patient, it's every 15 minutes. They will burn you on this on the exam. They'll say, how often should you reassess the patient? The wrong answer is every 2 minutes. It's every 5 minutes. So they're going to give you some wicked sick patient and be like, how often should you do a reassessment? It's every 5 minutes, not every minute, not every 2 minutes, not every 3 minutes. It's every 5 minutes for unstable patients, okay? And so they will be evil and put shorter intervals on there for you. And for stable patients, it's every 15 minutes. With that said, you're going to be say for erring on the side of caution and saying, well, the patient with abdominal pain, I reassess their blood pressure every 5 minutes. And I did another exam every 5 minutes. I reassess every 5 minutes versus saying, oh, they're stable and they're really not. So when in doubt, err with the side of caution and reassess more frequently. But really, we don't want to reassess it more than every 5 minutes, especially blood pressure. Um, because you're not going to really see big changes within, typically within a minute or two, you're not going to see big changes. Not only that, when you keep squeezing on the same arm, you're going to get false readings on the blood pressure if you do it too often, too frequently. Okay. Now that's it for this chapter. Again, I know this is overwhelming. We're going to go over this a lot in lab, in class. This is like a full day of really digging into some scenarios and doing things right and doing things wrong and debriefing and talking. How do we get really good at this to lay down a foundation? And once we do this in class and once you read this in your book and you start feeling more comfortable, I challenge you to do this with like a partner, a spouse, or a boyfriend or girlfriend, or a friend, or a brother or a sister, or a mom or a dad or a grandma or a grandma, someone who will let you assess them. And man, it might be a teddy bear, right? And just working through your exam and doing your head to toe exam, you can get a lot of value doing this in low stress environments at home prior to stepping into an ambulance with someone who's dying. And prior to stepping into lab when everyone's looking at you, right? And we try to make lab low stress, but I'm just saying, you have an opportunity to assess those around you or even yourself. You can listen to your own lung sounds and own guts and stuff like that and press on your own abdomen and see what you can find. So just be aware that this can be assessed at home. And I think you should be doing this at home. I know when I was in EMT school, I have three brothers and my mom and my dad, and I was like, let me do it. Let me listen, right? Let me feel. And so I was assessing them, right? And thankfully my mom's a nurse and paramedic, so it's helpful. But just be aware that you can assess this at home, and I think that you should be assessing this on as many as people that will let you. Okay. Now, with that, I appreciate your time, and that will end this video. Thank you so much.